یک سال سر میکنیم شروع شد. سلام بله همگی مسئولین محترم و با دکتر سایبا. نام من میوند احمدزی هستم. من فعلا در شهر زوریخ مملکت سوئیسرلند در Department of Radiation Oncology کار میکنم. در سال چهارم هستم و بخیر به سال کانسالتنت میشم و امروز ما میخوایم که شما برای Basics of Oncology و specifically برای breast cancer صحبت بکنم. سوالا رو میتونین داخل بکنین به زبان فارسی یا پشتو و لکچر ما به زبان انگلیسی پیش میبرم. چون که وقت ما یک ذره ضیق است، خواهش من است که سوالا رو بیشتر نوشته کنین، یادداشت بکنین، باز آخر بارش ما صحبت میکنیم. امروز ما استراکچر پرزنتیشن تو است که اول ما برای کانسر یا سرطان عموما صحبت میکنیم که چی است و بعد از او ما میبینیم که کدام سرطان خصوصا در دنیای غرب مگم در تمام جهان است و کدامش مهمترینشان است، دلیل سرطان چی است، کدام دیاگنوستیکس کار داره عمومی و کدام تراپی عمومی میشه. واضح است که ما متاسفانه در یک لکچر نمیتونیم تمام اسپکت ها رو برای صحبت بکنیم. بخاطر از این ما در کیس دقیق سر برست کانسر با سعی میکنیم و لکچر به زبان انگلیسی ما پیش میبریم. So what is cancer in general? I think we have medical students in different stages here, so therefore I'll just have a quick recapitulation of what cancer actually is. So if you look into the center of this image, we see normal cells, and there are different processes which can occur, which then lead to cancer. But there are also physiological processes, for example, hypertrophy. If we go to the gym and make sports, our muscles grow, so it means the individual cells grow by themselves, but we might also have some to a certain degree hyperplasia. It means we not only have cells that have grown, but we have also more cells. And if when we grow older and we don't move, there is a process called atrophy. It means the cells, they don't necessarily reduce in numbers, but they just shrink in size. And these processes are normal. They occur every day. The problematic part is when we have a normal cell that starts to develop a life of its own. It means it evades control by the body is not able to control it anymore, and this process, it's called first metaplasia, and afterwards, after metaplasia, we have dysplasia. And dysplasia is the dangerous state. It means the cells are not controlled anymore by the bodies, their biological function has changed, and they have the potential to spread and cause cancer. When we look at cancer in general, we need to understand what it actually is, and therefore it's important to recap quickly the histology part. So we graduate cancers according to TNM system. It means we look at the tumor size, we look at the lymph node involvement, which you can see in the green, and M means metastasis. We also look whether this tumor has spread to distant places, for example, to the bones, to the liver, lung, or brain. And from this picture, I want you just to have a general concept and remember that this classification exists depending on the size. And it's important to also understand that the basement membrane is probably in this picture the most important one to remember, because as long as the basement membrane is intact and not broken, then it means that the tumor is not able to evade and go to different places through blood vessels or lymph node vessels. But the second the basement membrane is broken, it means the tumor can, in theory, spread to the whole body. This is from a paper. Afterwards, after this lecture, I will provide you with all the materials needed. These are probably 30 to 60 pages, but if we want to understand what cancer is and what it why is so difficult to take care of it or treat it, we have to first understand how it behaves. So what do cancer cells do in general? First of all, they evade growth suppressors. It means the body cannot tell the tumor cells or this dysplastic cell not to grow anymore. Furthermore, it avoids immune destruction, so the immune cells cannot destroy these cells. In addition to that, we have enabling replicative immortality. It means that these cells, by definition, cannot die anymore because they lost their the DNA program which they had initially. Furthermore, in order to grow and make sure that the blood vessels are spreading into the tumor, they induce or make sure that there is an access to the vasculature, and they promote tumor-promoting inflammation. So we can see it's quite complex. Some of them can be also summarized in the one point, but to give a general understanding that the tumor has endogenous changes, but it also interacts with its environment, the DNA is changed, it resists cell death, and it has a deregulated metabolism, which is very different from the original metabolism. And furthermore, we have change in signaling. It means this tumor cells constantly tells itself to grow and make sure that it spreads to other parts of the body. Novel concept, this is a paper from 2022, for example. They also have analyzed that it's not only the tumor and the microenvironment which makes what cancer actually is, but there are also other sides that are important. For example, the microbiome in our bowel system, on digestive system, or our age. Furthermore, non-mutational epigenetic reprogramming, meaning that if we inherit a certain DNA information, it's not necessarily that it will have an impact and lead to cancer, but in some cases it has. So we see there's a huge complex web of different factors leading to the complexity of cancer. Now, if you look at the most common cancers in the Western world, we see that the lung is the most common one. On the left side, we have the incidence. It means how many of these cancers are actually present. And on the right side, we see how many of them are responsible for death. So lung cancer, for example, is the most common cancer worldwide. 11.6% of all cancers are lung cancers. But if you look at the mortality, we see it's higher. It's roughly 20%. It means that lung cancer is not only very common, but it has also high mortality. And in contrast to that, we see breast cancer, which is the second most, or also could be even considered the first, the most common cancer. There we see that despite having incidence of 11.6%, meaning out of all cancers, 11.6% are breast cancer, but the mortality is quite low. So it means breast cancer, despite being abundant, but the treatment is quite advanced and the prognosis is much better than, for example, for lung cancer. Furthermore, we have colorectal, it means rectal cancer, prostate cancer, stomach, and so on. And the most important thing for you is to remember that lung, breast, colorectal, or prostate are the most common one. And if you look at the mortality, Dr. Moman Sahar, I would like you to write down your question because we don't have so much time and there are a lot of participants. And at the end, I will answer the questions if you agree to this. So from this picture, for me, it's important for you to have a general grasp.
اگر میشه امیر با فارسی هم تشریح بکنید که کم بهتر بکنید.
کدام نقطه را به فارسی ترجمه کنم؟ می تفاوت اینی دو نمره را میگین؟
نه این سلایت خواستان برسادی
Dr. Sabilas, are you there, please? Wait, please, wait. Dr. Sabilas, are you here?
Yes, sir. Yes, sir.
Please control the room. سایکونه نونا برای شما گفته که بعداً براتان وقت 15-20 دقیقه داده میشه. شما هر سوالی که مطرح میکنین پرسان کنین. در این فهمیدن بسیار آسان است. نوشته است که most common cancer in Western world. اونجا نوشته است لنگ. اگر لنگ نمیفهمین دیگه I don't think you need to be in medical school.
نه استاد منظور می سلاید نبود.
Please stop it. Stop your mic, please. Please continue. Internet के एक lecturer हमारे जब यार This is advanced medical studies, clinical studies in جا خوش ما يتر كذا نمی تانیم که هر چیز رو ما شبار شما تشریح کنیم. Don't interrupt, please. Take your time and your question. Thank you. Please continue, Dr. Maiman.
چشم. هر سوال که بود خواهش میکنم هر کس که میرنگ بکنه ایره نکنه من نفهم چی رقم استاپ میشه و وقتی که لکچر خلاص شد هر سوال که بود او را به فارسی و پشتو حتما ما جواب میتیم. مهم نقطه ای است که اینی سه سرطان مهمترین شان هستند و چی تفاوت از است. فرض مثال برست کانسر که است به تناسب لنگ همچنان 11.6% است. مگر هم 6% مردم از بین میبره. این تنها یک نقطه مهم بود از این. دکتر سبیلیاس میفهمید چه رقم استاپ میشه که کس نتونه رنگ بکنه ایره؟
دکتر صاحب معلومه پن که است بالای معلومه پن کلیک کنین اموجا میتونن لیمیت کنین اون.
بله باشین خیلی clear all drawings on a limit شد. بله
لطفا محصولین عزیز نوشته نکنین و نگذارین ما می لکچر شما در هم میزنین. رقم هر روز براتان تشریح میکنیم، بسیار بد است. همتان میفهمین و به این سیستم ها بلد هم شدین. دیگه لطفا بالای اسکرین نوشته نکنین. ما بسیار به مشکل دکتر صاحب در این مشکلات، در این حالات سخت اونا وقت خدا بر شما سپیر میکنن، می اینجا براتون لکچر میگین. لطفا بالا اسکرین نوشته نکنین. دکتر صاحب شما ادامه بدین لکچر.
بله. So, and now if you look worldwide how the distribution of cancer is, we see that there are big similarities. We see that breast cancer, the red dot, cervical cancer is the yellow one, colorectal is the green one, and lung is the blue one. Furthermore, we have prostate and stomach cancer. So if you look at Europe, we see that breast cancer and colorectal are the most common ones. In North America, we see a slight difference. They have prostate cancer, the most common one. The second one is breast cancer, and the third one is lung cancer. In developing countries, we see a difference here, right? Cervical cancer. It means in Africa, for example, despite breast cancer being the first one, we have a much higher incidence of cervical cancer. There are several reasons for that, which we cannot discuss in detail now, but it's important to remember that worldwide, there are some differences when it comes to the incidence and prevalence of cancer. Here we just look again at the prevalence in the United States. And for male, we see the most common one with 20% is prostate cancer. And for females, breast cancer with 30%. But if you look at the mortality, so which cancer really kills a patient, there we see a difference, because lung was just with 14% a second one when it came to the incidence. But in mortality, it's leading with 27%. Same counts also for females, where we have breast cancer responsible for 30% of cancers, but lung cancer is responsible for almost a quarter of all deaths related to cancer. Now, what causes cancer? Very difficult question, which I try to represent as simple as possible. And we have here 6 examples for which I have 6 different cancers for us to understand that there's a variety of mechanisms that lead to cancer. We have on one hand, mechanical stress, we have physical stress, chemical stress, DNA and behavior, as well as viruses, which can cause cancer. So if you look at the genetic level, for breast cancer, for example, if you have the genes for the breast cancer 1 or 2, or somebody in the family, then the probability that you will develop breast cancer is much, much higher. For skin cancer, for example, ultraviolet radiation means sunlight is the main cause for developing different kinds of skin cancers. And if you look at chemicals, there we have benzol and other products that lead to leukemia. It's also very interesting to understand that also viruses, which was not understood until recently, that they can also cause cancer. For example, cervical cancer or oropharyngeal cancer is caused by HPV virus. And the most known or most prevalent cancer is caused, of course, by smoking, meaning lung cancer. Other organs which have the characteristics to have cell division at a very high rate, for example, if you look at the esophagus, there we have mechanical stress, but also the natural function of the esophagus, that the cells are dividing quite fast because we use it every day. There we develop esophagus cancer. Now, if you look at the causes, well, what are the preventable causes of cancer? So what number of cases per year could have been prevented if we focused on reducing smoking, doing exercise, reducing obesity, or reducing our sun exposure? There we see that, for example, more than 50,000 deaths could be, or cancer cases could have been prevented if we reduced smoking, or obesity if people did more sports and exercises by more than 20,000. Same goes for sunlight, also occupational or infection or alcohol consumption. So we see to a certain degree, we have also impact on which type of cancer we develop or whether we develop cancer at all, meaning lifestyle. Now we'll go in general to the diagnostics. So we know roughly what cancer is, what it's caused, where it could be, but which kind of diagnostics do we need if a patient is there and it's difficult to generalize for cancer because it could be anywhere in the body, but I'll try to give a general overview of how the diagnostics should be approached. It's quite general, but I think it's useful to get into the topic. So the first one, the most important thing is clinical observation. During clinical examination, it's very important to look at the patient, which symptoms he has, which family history, how he describes whether he has pain, whether he had lost weight, whether he had fever, or different kind of symptoms. Sometimes for skin cancer, you can also observe it with your eye. And sometimes we need maybe probably blood analysis. For example, for prostate cancer, there's possibility to detect the cancer by measuring PSA, that's process-specific antigen. We draw blood, and we have there quite a good idea whether it's the case or not. Furthermore, we use ultrasound, and then it's important to have also a biopsy, because that's the most important diagnostic tool, or probably one of the most important one, because without the biopsy, histological confirmation, we cannot say whether the patient has cancer, and if he has cancer, which type of cancer it is. Then advanced imaging is used with, for example, by using CT imaging or MRI, and in many countries we also use PET-CT. PET-CT is very interesting because it doesn't only provide morphological information, whether there's a cancer or not, but also a metabolic information. What we do in PET-CT, we give glucose that cannot be really absorbed or metabolized by the body, and it's marked. So we tell the patient, please don't eat for 6 hours. Then we inject this already actively marked glucose to the body, and we see where there's a higher or unregularly high uptake of that glucose. And that's a sign for tumor cells, because they have a high metabolic rate, and what they will do, they will try to get all the sugar that has been done, and by absorbing this sugar, they expose themselves in the PET-CT imaging. On the right, we see in PET-CT imaging, there's a metastatic patient where we see liver metastasis, mediastinal metastasis, and this also helps us to understand at which stage the cancer currently is. We have a picture here. Probably Dr. Zadroncev is much better suited to explain what we see here. This is a general picture of an cranial MRI or brain MRI, where we see on the left side, which you can probably guess, contrast uptake, and these are lesions or metastasis, which showed uptake of contrast enhancement. And this also helps us to detect and explain and say whether this patient has brain metastasis, yes or no. So you see there's a huge variety of different kind of diagnostics, but the most important, the first one is the clinical, and then we go step by step. And we also see that at the end, we probably will not even need PET-CT imaging if we can see by the biopsy, ultrasound, or even CT, which cancer it is, at which stage it is. Now, regardless of which cancer it is, we need to somehow grade it. We need to understand, we need a language, we need to be able to communicate with each other and say, okay, my patient has, for example, breast cancer or lung cancer, but how big is it? So how do we actually classify cancers? And there we use the international TNM system, where we look at the tumor size, we look at the lymph node involvement, and at the presence of metastasis. And in this schematic case, we see that T0 would be that there is no cancer, T1 is a certain size, and it depends. For some tumors, the limit between 1 and 2 can be 2 centimeters, 5 centimeters. This is something where TNM system is applied for each cancer individually. But this graph is very important to understand the general concept, how doctors grade cancers. Now, if you look at general treatment for cancer, so how do we decide which treatment is necessary for which patient? And probably the most important question is always to understand whether this tumor stage is local or systemic. Local means there is a certain area where we see a tumor, it hasn't spread anywhere else, and it's actually a local disease in that term. Systemic means the tumor has spread to different parts of the body where surgery is not suitable or useful anymore. There we need different kind of treatments. For local therapy, there are two established methods. One is the classical surgery, and the second one is radiation. In systemic stages where disease has spread beyond the local borders, we can use hormone therapy, classical chemotherapy, or also the novel targeted therapy, which are more specific and which I will explain in a while. Now we will look at breast cancer. So we now understand what cancer in general is. We understand how we need to grade the cancer, which system we need. And this is an example. Let's imagine this one is, for example, 2 centimeters, and there is no lymph node involvement. The patient came up to the checkup, and the doctor could feel that there is something hard in the breast, did ultrasound biopsy, and has confirmed that this is breast cancer. So when we want to stage this, we first look at the tumor size. So is it less than 2 centimeters? Then it's T1, T2 is everything between 2 to 5 centimeters, and so on and so forth. And in this example, the lymph node involvement, if there are no lymph nodes involved, then it's N0. If we have lymph node metastasis to ipsilateral, meaning same side, or if they're movable and axillary, mean that they're in the axillary compartment, then it's N1. And as we can see, just like with the size, with increased size, the T number increases, and with increased involvement of lymph nodes, the N number increases. And the metastasis is quite simple. So either it's M0, no distant metastasis, which is very good for the patient, or M1, that we have distant metastasis. In this case, as I already said, if the tumor is roughly 3 centimeters and there are no lymph node involved, then we can say this is a breast cancer, and histology is this or that type. It's T2, N0, M0. And if you just write this one line, breast cancer, T2, N0, M0, every doctor in the world will understand to 95% what the problem is and what needs to be done. Of course, if it's necessary that all the diagnostics have been done correctly. Now, if you look at breast cancer, where do the lymph nodes go? So it means if we have somewhere the one sec. Yeah, okay. If we have somewhere the breast cancer, where do the cancer cell go? So the cancer cells, for example, here, they first travel to axillary lymph nodes. This is displayed in the axillary compartment. They can travel further to infraclavicular lymph nodes. And on the medial side, we have the internal mammary lymph nodes where they can travel, or also upwards towards clavicular or supraclavicular lymph nodes. So it's very important to keep this anatomy in general in mind. So it's important to look at the axillary, claviculary, and also the medial side. So I already showed what could be the causes of cancer, and this is a list. After the lecture, I'll provide you with all the materials that you need. This is from that material. I'll just quickly remove the annotations. So, and we see that for breast cancer, for example, estrogens are responsible for causing this cancer. And as estrogen is responsible for breast cancer, we have a high variety of different carcinogens responsible for different cancers. For example, androgens are responsible or can lead to prostate cancer. Arsenic can lead to cancer of the lung, and different, as already said, HPV virus to cervix, anus, or pharynx. So this list gives us a general overview of what can cause it. So now we know for this case, estrogens are somehow relevant in breast cancer, and this will be explained in the next slides why. So if you look now at the stages, what I just showed you, on the left, we see in early stage 1 breast cancer, it means the tumor is smaller than 2 centimeters. And on the right side, we see 1B, where we have lymph node involvement. As you can see, there are clusters of cancer cells and axillary lymph nodes, and the tumor is also smaller than 2 centimeters. It means if we have no lymph node involvement, then it's stage 1A. If there's lymph node involvement, then it's 1B, and it's important that the tumor size is 2 centimeters or smaller. Now, the general overview. So what do we do? If we have a patient who fortunately doesn't have distant metastasis, it means it's M0. So how can we treat these patients? And in the past, what surgeons did, they removed the whole breast. So it was called mastectomy. You remove the whole breast. It was horrible cosmetic result, associated with a lot of pain and suffering for the patient. But recently, in the last 30, 40 years, the surgical techniques have been improved so much that for the majority of cases, you can conduct a breast conserving surgery. I'll just quickly mute everyone again. Yeah. So this is one example where we removed the tumor with a certain margin to make sure the tumor is not there. And afterwards, we just need an adjuvant radiotherapy. And on the right side, if, for example, the localization of tumor is difficult or is too big or too large, or if there's lymph node involvement and there are some other complexities, then we can also still conduct a total simple mastectomy where we remove the complete breast. Now, if you look at the breast cancer standard treatment options, so what do we have? And if you remember the first picture that I showed you, the general one, how we treat cancers, do you remember? So I told you this is very general, and now you'll see how it's applicable or applicable to breast cancer. So we see the same here. If it's local disease without distant metastasis, then it's enough to conduct surgery. There we can remove just part of the tumor called lumpectomy, or remove the whole breast, and afterwards conduct the adjuvant radiotherapy. If we have systemic involvement, or if it's localized but still has large involvement on lymph nodes, then we can think about chemotherapy. Hormone therapy is recommended for a huge majority of patients. And we have also targeted therapy, which is used for patients which are at high risk, or sometimes even for metastatic patients. Now, surgery of breast cancer. So why is breast cancer surgery required? It's required in order to make sure that there's no recurrence and no local complications. There are different varieties of how to conduct the surgery, but the two important ones are lumpectomy, where you just remove the tumor, and the second one is mastectomy, where you remove the whole breast. And the cause is actually to make sure that the tumor or cancer is eliminated, there's no progression of cancer, and there are a huge variety of techniques how to reconstruct the breast. You can use either an expander or artificial material, or you can take material or tissue from the patient itself, for example, for the belly fat tissue, and place it there to make sure that you have a good cosmetical outcome at the end. Secondary, it's important that almost all patients need adjuvant radiotherapy, because despite removing the whole tumor, there's possibility that certain cells or few cancer cells remain in the tissue, and therefore it's recommended to conduct the adjuvant radiotherapy. Radiotherapy is just X-rays at high energy level, and they are more to understand why it actually works is tumor cells lose the ability to repair themselves, and normal tissue cells repair themselves quite well. And with radiation therapy, we are able to specifically eliminate the remaining tumor cells and make sure that there's no recurrence. Hormone therapy for breast cancer. Why do we need it, and what should you remember? You should remember that there's one hormone that's called aromatase, and aromatase converts androgens into estrogens. And if you remember from the slide I showed you previously, estrogens are responsible for breast cell growth and also indirectly then for breast cancer. So it's necessary to make sure that the patient who is responding to hormone therapy receives hormone therapy to reduce the estrogen levels. And what letrozole does, it goes and blocks the aromatase. If you just remember this information, that's the most important one. There's a huge variety of different substances that can be used, but the principle is that we need to reduce estrogen levels. And how can we do it? We need to stop aromatase. And aromatase can be stopped with letrozole, and letrozole is given to all patients who are estrogen receptor positive. That's something which we analyze in histological examination. Now, chemotherapy is given to patients with systemic involvement or very large local involvement. And to decide who receives or which breast cancer patient receives chemotherapy, yes or no, it's quite complex. In general, you should remember that there are different scores. So you take the tissue of the patient, and there are a variety of genetic tests. And if this genetic test tells you that the recurrence score is low, for example, 11, then it means we don't need chemotherapy. The endocrine therapy, which I just showed you with letrozole, is enough. But if the genetic composition of the tumor shows that the genetic makeup has a more high risk constellation, and we have a recurrence score above 25, then we need chemotherapy and endocrine therapy. And the two most commonly used chemotherapies are anthracyclines and taxanes. And how do they work? So the green one is just a DNA double strand. It means that's the DNA of tumor cell. And what this chemotherapy does, it goes and this interlocks between the two DNA strands. So it actually, in parts, disturbs the transcription and the metabolism of the cell by just going and blocking the DNA of tumor cells. Targeted therapy, this is something also very, very important. I already said it, we have different systemic therapies. One of them is endocrine therapy or hormone therapy. Second one is chemotherapy. And the third one is targeted therapy. This is the most advanced therapy called, which I now will introduce to you, trastuzumab. As already said, there are different genetic makeups of the tumor. And if the patient has HER2, this is a receptor that's responsible for tumor cell growth, tumor cell division, then we give the patient trastuzumab, which blocks this HER2 receptor. And you can see trastuzumab, that's the red antibody, going and blocking these receptors and making sure that we inhibit the cancer cell proliferation, and we have an antibody-dependent cytotoxicity, which means that these antibodies specifically kill these tumor cells. A very important side effect, and that's something you should also always remember, whenever we use this targeted therapy with trastuzumab, we also have one very important side effect, and that's cardiotoxicity. This receptor also goes to HER2 molecules on cardiomyocytes, means these HER2 molecules are also present on the heart muscle cells, and whenever they affected, they can also lead to cardiomyocyte dysfunction. That's why it's very important to always do ultrasound of the heart before start of treatment with targeted therapy with trastuzumab, and always make sure that there's a good, close clinical follow-up of the patient. Now we will come to the case. We will look first at the case, go through the case, and at the end, answer all questions, because I'm very sure when we answer the questions regarding the patients here, this will solve a lot of questions which some of you might have. So I'll read this case, we'll think a minute about it, and then see what the most likely diagnosis could be. A 55-year-old postmenopausal woman presents her to primary care physician for annual physical examination. She has no complaints, feels healthy. On physical examination, she's afebrile with a heart rate of 80 and blood pressure of 140 to 85. But during the breast examination, a small, hard, fixed nodule is palpated in the upper outer quadrant of the left breast. The skin on the breast is without abnormality. There's no nipple discharge. There's no abnormal lymph nodes palpable. And she sent for diagnostic mammogram, which reveals a 3-centimeter nodule with microcalcifications. A corneal biopsy is scheduled, and the pathology report reads that it's invasive ductal carcinoma without clear margins. It's estrogen receptor positive, and the HER2 receptor is negative. This receptor I just showed you. So what's the most likely diagnosis? And you can answer quickly if you want to.
Breast cancer.
Yeah, very good. Why would you think that?
Because in diagnosis also said a small hard fixed nodule palpated in upper outer quadrant of the left breast. Because we said when we have nodule in breast, and because of that, I think it's breast cancer.
Exactly. And you said everything perfectly correct. So it's hard, it's fixed. So sometimes because of hormonal status, we can have some nodes, but in the majority of cases, they're not hard and they're not fixed. So this is something that makes us suspicious. And now we see this patient has breast cancer, as you said correctly. And excuse me? So this patient has breast cancer, but the stage is, of course, not yet determined because we just have a biopsy. And all new breast lumps found on a breast examination or mammogram must be biopsied in patients at the age above 35 years. The clinical features of this lump, hard and fixed, suggest that cancer is rather than a benign cyst or adenoma. Now the next question is, how are we going to stage this condition? How are we going to say how big it is, the involvement? What's going to be the diagnosis? You can answer the question if you want to.
Maybe some it's just not breast carcinoma.
Yeah, because this must be biopsied. We need a biopsy, and let's think that the biopsy was positive, that it's cancer. So how are you going to stage this? Which stage of cancer is this?
By TNM?
Exactly. Very, very good.
I think it is.
So, and let's go quickly back. So we have 3 centimeters, right? And then we have no lymph node and no metastasis until now. So which TNM would you give this patient?
T1, N0, and also
No, T2.
T2 offering, correct. Very, very
T2.
good. Exactly. So
N0,
we have something,
M0.
exactly, perfect. So we
T2,
have
N0,
T2,
M0.
M0. Very, very good. Very, very good. So I'll just quickly mute everyone again. Mute all. Okay. So perfectly said. We have T2 because it's 3 centimeters, N0 because there's no lymph node involvement, and M0 because fortunately this patient doesn't have this metastasis. Now, what risk factors are associated with an increased incidence of this condition? Meaning which risk factors are responsible for developing breast cancer? You can answer the question.
Can I speak to
Smoking. I think it's smoking.
Smoking,
Yeah, I think
and it's genetic. It's some viruses.
Smoking would be for lung cancer.
estrogen?
sorry, sir.
Yeah.
I think for that breast cancer, the most common cause or risk factor hormone like estrogen, and also
Very
obesity.
good.
Yeah,
Very good.
obesity, hormone like estrogen, progesterone, and some other cause.
Very, very good. Exactly. So you explained perfectly the physiological condition or hormones which lead to that. And if we translate it into a social environment, or if you look at the patient's condition, then we can quickly see what this looks in reality. So in reality, all these factors that you said are absolutely correct. And the breast cancer is the most common cancer and the second leading cause of cancer death in women. One of most important risk factors is estrogen exposure. How does this happen? So when do we have high estrogen exposure? When do we have little? And early menarche, meaning that if the transition from girl to woman is at early age, it means the exposure time of estrogen is longer. So this is one risk factor. Second one is late menopause. It means if there's a longer duration of time where a woman is biologically reproductive, she's exposed to higher estrogen or more estrogens over time. And nulliparity, meaning that if the woman doesn't give birth to a child and doesn't breastfeed. So these are factors. So you can imagine that a woman, for example, who got her menarche maybe a bit later and got the menopause earlier, had 3-4 children, has always breastfed them, that's a patient that's protected well, usually against breast cancer. And if a woman, if she developed her menarche quite early at the age maybe of 13, 12, and the menopause came quite late and didn't have children, never breastfed a child, she has a higher risk of developing breast cancer. But for most women, we have no identifiable risk factors other than age and gender. And there is a association with personal or family history too, and of course the breast cancer gene 1 or 2. And this if you have this gene of somebody has, it's quite aggressive, and that's why it's very important to look at the family history. If the grandmother, aunts, the mother, if they all had breast cancer, then it might be relevant to also look at the genetic composition, to do genetic examination, especially if the patient developing breast cancer is quite young. Overall, the average risk of a woman in the United States developing a breast cancer in her life is about 13%. It means that 1 out of 8 women has a chance that she will develop breast cancer. Now, what is the most appropriate next step? So you've done the examination, you've done the biopsy. What would you do now with the patient? You can answer the question now.
Local air metastasis.
So when we diagnose she has like breast cancer, after that we start the treatment.
But have you completed your staging?
Right?
Exactly. So we need to look at this stage, what she has, the whole staging to make sure that we have all the information, and then we can go into the treatment correctly. In patient with small isolated carcinomas, breast conservation therapy, which I showed you, this lumpectomy plus adjuvant radiotherapy, is equally effective to removing the whole breast. So it means if the tumor is small, you can remove it well, just remove the tumor, leave the breast in peace, do the radiotherapy in addition, and it's as good as removing the whole breast. Whichever surgical approach is chosen, and sentinel lymph node sampling should be done to make sure that there is no involvement of lymph nodes. So what you actually do, you take some color, inject into the breast, and then look where they travel to the lymph nodes. And if you have the color in lymph nodes, you isolate lymph nodes, you look at them under the microscope, and if you see that there's no tumor, then you know, okay, this tumor just stayed in the breast, didn't go to the lymph nodes. At this early stage, metastatic workup requires a complete blood count, liver function test, and optional bone scan. A CT scan for chest and pelvis is indicated in stage 3 patients, which is not the case here. So for her, it would be enough if you just look at the blood count, liver function, and maybe if we have the possibility, availability, just do a bone scan to make sure that we don't overlook anything. And the breast cancer metastases go usually to four main destinations are 4 places. This the bones, lung, liver, and brain. But for this patient, this is not relevant, just for us just to remember where does the breast cancer metastasis go. What pharmacologic treatments are available for this patient?
Hormone therapy is the first.
Yeah. What else?
Hormone therapy.
Chemotherapy, hormone therapy, and after that, when it's targeted therapy, and also after that, mastectomy.
No, mastectomy will not need for this patient. No.
So I think it is the hormone therapy, chemotherapy, and targeted therapy.
Therapy.
Okay,
Exactly.
because it is systemic. Yeah.
Exactly. So for her case, fortunately, this is not systemic. And now we'll just look at the systemic therapies, which you already mentioned. It means, first of all, the hormone therapy, then chemotherapy in general can be given, but in that case, it's not necessary because it's early stage, and targeted therapy if she has this HER2, for example, right?
Okay.
So now adjuvant chemotherapy and or hormonal therapy have been shown to improve outcome and prevent recurrence in early stage cancer. But in general, in majority of cases, it's not quite easy to say, okay, this patient needs chemotherapy or not, because I showed you we need to do also this genetic analysis and see, okay, how is it? Is it aggressive tumor? Yes or no? But in general, we can say if the tumor is not aggressive, it's early stage, then we need hormone therapy. And when the most important thing to remember is here, whenever we do the histology, of course, we do the TNM, we know, okay, how big is it? But we always need to look, okay, is this tumor estrogen receptor positive or not? Because if it's positive, it means we can give tamoxifen or these hormone therapy because these tumor cells will respond to it. If we give hormone therapy to tumor cells which don't respond to hormone therapy, it doesn't make sense. That's why we always need to check TNM. In histology, we look for estrogen receptor positive or not positive. In this patient, it's positive, means this patient's estrogen receptor positive, so she would benefit from hormone therapy with either tamoxifen or aromatase inhibitor. These are different substances which do actually the same work. After this lecture, I prepared material for that. We have extensive information with videos, with references, explanations, which I'll provide to you through Dr. Zadran. But for you, just to remember, estrogen positive or negative, and if positive, we give hormotherapy.
Hormone.
Anastrozole is indicated in postmenopausal patients. This is a little bit too much in detail, but since we're good in time, I'll just explain it. So when you do hormone therapy, you also need to look, okay, is the patient reproductive? Is she before the menopause or after menopause? Then you choose just a different kind of hormone therapy, but the principle is exactly the same. And all patients.
Sir, can we do hormonotherapy with chemotherapy together?
Yeah, of course, yeah. If, for example, if in this case, for example, let's take this case. We see small tumor, estrogen positive, but in the analysis we see it's very aggressive. The tumor divides very fast. The genetic composition is high risk. Then we give chemotherapy and hormone therapy. The chemotherapy is done after a few cycles, and the hormone therapy is kept for 2 or 5 years.
Okay.
All patients in stage 2 or higher, receptor positive cancers, would benefit from a course of chemotherapy before the start of hormone therapy, and patients with overexpression of HER2 receptor would benefit from trastuzumab. And whenever I said trastuzumab, which organ can be damaged by it? Do you remember?
Heart.
Can you please repeat it?
You repeated the question, sir.
Myocytes.
Exactly, heart muscle.
Cardiac.
Exactly. Very, very good. Very, very good. So what do you think? What's the prognosis for this patient? We said early stage, just lumpectomy, remove the tumor, do radiation, give hormone therapy. This is early stage. What's the prognosis? So this patient comes to you and asks, Dr. Sepp, what will be my prognosis? What will you say?
Dear sir, it could be the systemic malignancy.
In this case, not. And this was just localized, early stage. The tumor was removed completely. We did adjuvant radiotherapy and gave hormone therapy. There was no need to do chemotherapy or remove the whole breast, and the CT scan showed there is no systemic involvement. So this is just localized, and now the procedure is done, and she's coming 3 months after treatment and asking you, what is my prognosis with this disease? What will you say?
The cancer at early stage, it has a good prognosis, but
And
because it doesn't spread to any lymph node.
The
exactly,
prognosis will be very good.
Exactly. It's very good. And if she asks you, what is the probability that I will be healthy and alive in 5 years? What's the percentage? What would you say?
Above 90%.
Very, very good.
Yeah.
Exactly. Breast cancer in early stage is curable with 5-year survival rates for strictly localized and receptor positive tumors, which I just showed you, is being above 90%. And stage 4, which means that the patient has unfortunately metastasis at distant organs, is almost always fatal. But in this case, we have a good case, we understood it, and the patient can now, it's just important that the patient does every 6 months the mammography, goes regularly to the gynecologist, checks it up always, and she's good to go. Okay, thank you very much. We can now come to the questions which you have noted down. So let me see who's raising. Dr. Muqaddas Saib, Mirabani.
Hello, sir. Hello, can you hear
Mirabani,
me?
yeah, you can ask question Pashto, Farsi, English, whatever you prefer.
Okay. My question is this, that if the patient didn't have any genetic problem, is there any another reason to having this kind of cancer?
Yeah,
yeah, so it's a good question. So the genetic, as already said, let me just find it quickly. Yeah, so for the majority of patients, we don't have
دکتر
any
صاحب مایوان
identifiable.
یک دقیقه است برام بر محصلین یک چیز تشریح کنم.
مهربانی بفرمایید دکتر صاحب.
خب محصلین عزیز، شما یکی از بیشترم براتون ما تشریح کردیم. وقتی که میخواین سوالتان مطرح کنین، پیش از او لطفاً خود معرفی کنین و بعداً وقتی سوال میکنین بگذارین که دکتر صاحب پس همون محصل خودشان جواب بدن. لطفاً شما انترپت نکنین، مایکتان آف بگذارین و دستتان بالا کنین. ما شما را اجازه میدیم که شما سوالتان مطرح بکنین و دکتر صاحب براتون تشریح میکنه خودشان. اجازه به محصلین نیست که شما جواب بدین لطفاً.
دکتر صاحب الیاس تاسو کیمرا هم ده.
Dr. Seb, Muhtaram Muqaddas Seb, so as already said, for the majority of patients, we don't have strictly identifiable risk factors. So we cannot say if you have this genetic association, then this will happen or you will get it. But we can just see from the epidemiology perspective that estrogen exposure, early menarche, late menopause, no children, no breastfeeding, this increases in general the chances, but it doesn't mean that every woman that has these risk factors will develop breast cancer. And the genetic cause of this is not well understood. It's very complex. There's just one gene, this breast cancer gene, A1, A2, that shows that if you have this, you will develop breast cancer. But other genetic constellations which could lead to that, they're not known. And I've prepared the material for that where you can read it. It's very extensive. It's like 30, 50 pages. Probably one of the best material to understand this, and also for medical students. And Dr. Zadron will provide it after the lecture into the WhatsApp group. They can read more detail about it. But in general, what is written here, that this is the clinical standard currently. So, Dr. Saib Parveen Mirabani.
Okay, I have a questions about radiotherapy. How we can use radiotherapy and which it means the patients how old become it means چند ساله باشد که we can use radiotherapy. Thanks.
Yeah, radiotherapy is regardless of age. So it means we use radiotherapy for all localized treatments. It means whenever a surgery was done and tumor was removed, we conduct the radiotherapy. Unfortunately, as far as I know, there are no radiotherapy facilities in Afghanistan, but in other countries or worldwide, this is a general standard. And radiotherapy is just X-rays with higher energy, which go and damage cells. Healthy cells can repair themselves, tumor cells cannot repair themselves. In general, the treatment of radiotherapy takes 2 to 3 minutes. It can be done either in 5 sessions, it means from Monday to Friday, and the patient is done, or it can be done over 3 weeks. Side effects are that the skin gets a bit reddish, they will have a little bit pain, but not really relevant, and they feel tired. So these are the most common side effects. It's standard treatment for all localized breast cancer cases where we have conducted removed tumor and the breast is still there, and age is not a limit there, so it can be any age. Dr. Saib Rawar Mirabani.
Hello, sir.
Mirabani.
I don't know if it was my name or not. Last year of my question was about like patients who are in the last stages or like late stages and have transferred or like metastasis to other parts of the body. Can we perform surgery or do we recommend medicine just for the patient's comfort?
Dr. Saib, could you please repeat the question? I could not hear well. Maybe talk a bit louder.
Okay. Patients who are in the last stage and have metastasis to other parts of the body, can we perform surgery or do we recommend medicine just for the patient's comfort?
Very good. So, for example, let's look at a patient which is advanced stage. Okay, let's say the tumor is quite big, and we have one metastasis at the leg, okay, or liver. It doesn't matter. And now you remove this metastasis with surgery, and this one and that one. Okay. So day 1 after surgery, can you say that this patient is tumor-free? You cannot say it because the probability that they have metastases which are not detectable yet, that you cannot see, it's too high. If you do surgery here, then 3 weeks later, the patient has another metastasis at different parts of body, in the brain and everywhere, and you cannot remove them all. That's why, per definition, if you have metastatic lesions, then you give systemic therapy. But in modern therapy now in Western Europe and America, what we can do is if we give systemic therapy, this patient has, for example, 5 metastases, okay? We give systemic therapy and this patient has now only 2 metastases left. So in that case, we can say, okay, if that patient has now only 2 metastases, then we can do radiotherapy because this patient is has metastasis, but not polymetastatic. He doesn't have more than 5. It's less than 5. Systemic therapy has worked, but not perfectly. And now we will do radiation. And with radiation, you can treat brain metastasis or lung metastasis. And this patient will live a bit longer then. So this is the maximum we can do with very advanced radiotherapy. And this is not also standard. We are still working on that in Switzerland and Western Europe. That's the maximum we can do. But if patient has advanced stage 4, you have to do systemic therapy or palliative therapy, and surgery can be necessary, for example, if the skin is open, if the bone is almost fractured, that you'll need some actually supportive surgery, but not curative surgery, where you remove tumor. You help the patient to cope with the symptoms. That's where you do surgery. But in advanced stage 4, curative surgery is not indicated, no.
Yeah, thank you, sir. Is it a specific, like the metastasis should be less than 5?
This is a concept, this is beyond what we talk about. So in the past days, or until now even, we say 1 metastasis, halos, patient is metastatic, we cannot do anything. But the new concept says, okay, maybe if the patient has up to 5 metastases, this is oligometastatic. It means a little bit metastasis or some metastasis, and not polymetastatic, means many metastases. And if a patient is oligometastatic, then we give systemic therapy. Then we can do radiotherapy to help the systemic therapy to take care of these lesions which could not be treated. But this concept is still in work. This is not in the books yet. People are working on that still.
Thank you, sir.
You're welcome. Dr. Saib Rasuli.
What are the big complications of radiotherapy and breast cancer?
Yeah, fortunately, almost none. So I do on daily basis radiotherapy adjuvant for breast cancer patients. 3 things we hear the most common. One thing is that they feel tired. In a way tired that they go maybe 1 hour sleep during midday or go earlier to bed. That's one. The second one is because radiation goes through skin, the skin is a bit reddish. It's like a little sunburn, and they use a cream and it's gone after 2 weeks. The third one, what can happen is that they feel an itching pain a little bit because the radiation also stresses a little bit the tissue, and they can have a little bit itching or little pain, which also goes away. And the third one is that the color of the skin can change a little bit, or the breast might shrink, might become a little bit smaller, and the skin less elastic. But these are mainly cosmetic side effects. This treatment is tolerated very, very well. It's standard treatment. Yeah, they feel a bit tired, and the skin is a bit reddish. That's what you see usually.
Thanks, doctor. Thanks a lot.
Dr. Saib Masuda.
سلام علیکم. سمستر 4 که مالبری هستم. سوال درباره بود مثلا وقتی کسی که سرطان بریست داره این میتونه به هر صورت تداوی شود، تداویش کلا مکمل شود و سرطان از بدنش پاک شود، چه قسمی میشه که به نسل‌های بعدیش انتقال شود؟ یعنی به خاطر که هر قسم باشه روی جنایش یا کدای ناقص برش میمونه.
بله، جست به انگلیسی جواب بدیم یا بدری جواب بدیم با شما؟
As you wish.
صحیح است. چون که دری ما در تفاوت خوب نیست، امور رو با گوش میکنم. دری اگر نشد باز انگلیسی خواهش میکنم.
No problem.
اتو هسته که اکثرت کیس که هسته اونجا از نگاه ژنتیک ما نمیفهمیم که دلیل چی هسته. و تو یک جین هم نیست که آدم بگه وقتی که عضو فامیل رو داشته باش آلاش 100% امورم برش میاد. تنها یک جین معلوم است. breast cancer A1 A2 و این دومیننت است، یعنی که اگر مادر کلان خانواده رو داشته باشه و به اولاد ترانسفر شوه، اولادش سرطان پیدا میکنه. باخته از این وقتی که در یک فامیل بفهمه دختر در سن 16 ساله یا 18 ساله که نمی جین داره او رو چک میکنه و اگر او دختر داشت و جینه پیش در سن 18 ساله 17 ساله چقدر بود اردودن برست او دور میکنن و عملیات های دیگر هم میکنن که پیش امو ارگانز که در خطر هستن سرطان پیدا شوه او را از بدن از نگاه جراحی دور میکنن. او را غیر این جین به دیگه جین معلوم نیست. باخته از اینجا دکترها اینی یک ریکورنس کد جور کردن یا میگیرن بایوپسی سامپل در اینجا نمیفهم 100 دانه 200 دانه جین چک میکنن باز رو انالایز میکنن باز میبینن که از این 200 دانه یا 100 دانه جین اگر این 15 دانهش های ریسک پوزیتیو باشه ما برای اینو تا یک ریکورنس کو میتیم و اینی نشان میده که چقدر مشکل است که آدم اول بفهمه که کی های ریسک است یا نیست که برای کیموتراپی بدی و دوم آیا که این جین به اولاد خود داده میتونه نمیتونه این معلوم نیست. تنها یک جین معلوم است برست کانسر A1 A2 و نموره اگر در آفزیتان با نگاه بکنین این مهمترین معلومات است راجع ژنتیک.
Thank you.
خواهش میکنم. دکتر صاحب ثابت.
سلام دکتر صاحب و تشکر از همه تشکر داشتم در ارتباط به همی البته سوال ما به دری میپرسم باز مشکل نیست شما به هر زبانی که جواب دادین ارتباط به برست کانسر و ایزوفاگس کانسر بود بله
دکتر صاحب آوازتون کم قطع
میشه برست کانسر میتونه و اونم کانسر از نوع اسکواموس سل کارسینوما خب شاید حال بهتر شده باشه سوال من بود که گفتم آیا برست کانسر میتونه باعث اسکواموس سل کارسینوما در ایزوفاگس شوه مثلا در خانمی که چند سال قبل سرطان ثدیه داشته باشه و دچار یعنی سرطان ثدیه شده و تداوی شده باشه و اون مشکلش تا حدی حل شده بعد از چندین سال یا بعد از چند سال دچار ایزوفاگال کانسر شوه او را هم از نوع همو قسمی که اول ذکر کردم اسکواموس سل کارسینوما امی چند فیصد مثلا امکانش میره که از خاطر سرطان قبلیش یعنی سرطان ثدیه‌اش باشه آیا امکان و احتمالش میره و اگر میره چند فیصد است و اگر بگوییم مثلا موضوع متاستاز در اینجا باشه خب فورا ایجاد نشده مثلا برست کانسر باشه بعد از یک چند مدت فورا این مشکل پیدا شده باشه او قسم نیست چند سال از این مدت گذشته امو خانم بعدا دچار امو سرطان مری میشه و این مشکل پیدا میکنه و قبلا یک تاریخچه از سرطان ثدیه هم داشته حالا چند فیصد احتمالی میره دکتر صاحب که از همو برست کانسر باشه فقط امیر میخواستم بفهم تشکر دکتر صاحب
بله خواهش میکنم بسیار خوب سوال است سوال یک ذره مشکل است بخاطر از اینکه اگه آدم مستقیم بگوید که فرض مثال این از تصویر ای چون که ادینوکارسینوما اگه باشه یعنی که این سلول است که خودش هورمون یا شیر تولید میکنه که بره و اونجا سکویموس سل شوه این از نگاه طبابت این نمیشه مگرم چه رقم امکانات داره که امی یک دلیل از او شوه یک امکانات از این است که این راستی یک متاستاسیس باشه که بایوپسی از او صحیح نشده بود متاستاسیس معنا نداره وقتی که این سرطان برست کانسر ما اسکن شدین دیاگنوز شد حتما امیال کل متاستاسیس معلوم شد امکان از این است که تداوی شوه 5 سال بعد یک جای دیگه متاستاسیس میتونه باشه نزدیک ایزوفاگوس اونجا اگه بایوپسی را که از غلط بگیره فکر میکنه که اسکواموس سل است این امکانات اولش است امکانات دومش این است وقتی که سرطان برست کانسر که داشت تداوی شد و کیموتراپی بهش داده شد کیموتراپی خوبیش است که سرطان از بین میبره معنی و بدی هم داره که این سلول نرمال هم سرش حمله میکنه و وار تشویق میکنه که سرطان شون خودشان چون که اونم برازوا دمیج میرسانه دی ان ایشون خراب میکنه یعنی که امکانات از این است که یک نفر آدم کیموتراپی بده سرطان برست کانسر گم شوه مگرم از خاطر امی دادن کیموتراپی یک سرطان دوم با یک نفر پیدا شود اینی امکانات شما است و امکانات سیوم شما است که متاسفانه یگان تا است که یک سرطان را دو سه تا نمیتونه داشته باشه مختلف باشه این هم یک امکانات است مگرم ای که خود برست کانسر مستقیم اونجا بره و سکواموس سل سرطان شوه این از با فهم امکانش نیست مگر متاستاسیس باشه یا سرطان علاجه دیگه بوده یا از خاطر کیموتراپی امکانات پیدا کردن ایزوفاگوس کارسینوما پیدا شده باشه این امکاناتش هست دکتر صاحب زرمتی
سلام جناب استاد سلام به همگی نام سریا عثمان است جناب استاد من استاژر هستم تمام لکچر خیلی عالی بود تشکر میکنم تمام مسائل را فهمیدم اما مکانیزم اوبیسیتی را در ایجاد کانسر نمیدانم اگر لطف کنین برام تشریح کنین تشکر
بچشم این یک چیز است که تا بالا ما صحیح نفهمیدیم که دقیق مکانیزم از این چی است و چرا اوبیسیتی این پرابلم پیدا میکنه با سرطان عموما. مگر هم در کیس برست کنسر بسیار خوب واضح است، براتون تشریح کنم میتونم. اغوماتاز را بر شما نشان میدم که اینجا بسیار مهم است، چون که استروژن تولید میکنه. اغوماتاز در کجا است و چطور اغوماتاز زیاد میتونه شود؟ اغوماتاز در فت تیشو است، یعنی که در چربی بدن است. وقتی که وزن زیاد باشه، فت تیشو زیاد باشه، همه غذات اغوماتاز میشه و در چربی بدن و در فت هورمون استروژن تولید میشه. یعنی که هرچقدر که وزن زیاد باشه، همه اغوماتاز زیاد است، همه استروژن زیاد میشه و از این تاریخ در این کیسز برست کنسر این از بهتر فهمیده شده این چی میکنه، یک افکت منفی داره از سرطان برست کنسر. اینی دلیلش است که وزن زیاد چرا اینی تکلیف امکاناتش بلندتر میبره. دکتر صاحب اکرم. دکتر صاحب اکرم؟ خیلی دکتر صاحب بابوری مهربانی.
Assalamu alaikum, sir. Sir, I have a question. My question is that if a woman has a breast cancer and if he or she feed a baby with her milk, and is this make a problem for her baby or not?
Usually it's important to understand at which stage this is happening. So for example, if a woman is not aware of that she might have breast cancer and she's breastfeeding, then in majority of cases, this is also not 100% understood, but because we have digestive system where we have in our stomach quite high acidity with pH levels up to 5 or 6. So it means whatever goes there will be destroyed in the majority of cases. But it becomes more complicated or difficult when she's receiving chemotherapy or hormone therapy. There it should be avoided breastfeeding, but if patient is not receiving any systemic treatment or local treatment yet, and they're not aware of that, it's not known, and therefore I cannot answer this question, but my guess would be it shouldn't be a problem, especially if it's localized small and the milk goes through the acidity of the stomach of the baby. That shouldn't be a problem. But whenever we have a systemic therapy and the patient is aware that she's ill, this shouldn't be done. Dr. Saib Shiva.
Hello, dear teacher. I have a question from you. What is the main treatment of benign tumor and malignant tumor?
Yeah.
Thank you. Please explain clearly.
Yeah, I will explain as clearly as I can. Benign tumor means, let me go actually even to the first stage. So benign tumor means here, can you see this? Tumor in situ. It means tumor cells are not normal anymore, but they have unfortunately not yet destroyed the basement membrane. And these benign tumors, they can be, for example, in the breast, they can be in our colorectum, for example, they can be also in skin. So there are different places where they can be also in the brain. There are a huge variety of different places, but if we focus on breast now, so if we see that's a benign tumor and in a biopsy, we see the basement membrane, which is the last door protecting the body, it's not broken, then we can say if the patient is very old, then we can say, okay, is a surgery needed? Probably not. We can leave this patient, for example, this patient is 90 years old and this has been there for years, then we can discuss it. But in generally, if it's a benign small tumor and in a biopsy, if benign means in this case that you can develop cancer from this, we can remove this surgically without that problem. And if it's not benign, then we need to remove it.
Teacher, I don't